This evening, I'm pleased to introduce you Dr. Bonham, who's a psychiatrist with an interest in access to care and developing community partnerships. She has worked as a psychiatrist, in the United Kingdom and Australia, and has been on faculty at UNM since 2010. She oversees the Division of Community Behavioral Health in the UNM Department of Psychiatry and Behavioral Sciences, which addresses health disparities among individuals with mental illness in New Mexico through community-partnered research, clinical and educational initiatives. She also serves as a psychiatric consultant for the New Mexico Behavioral Health Collaborative. Clinically, Dr. Bonham provides direct care through the UNMH Assertive Community Treatment Team and to rural communities through the UNM Telebehavioral Health Program. Please help me in welcoming her this evening. Thank you so much for joining us. We really appreciate it.
Thank you very much for coming tonight and for your interest in this topic. And please, all the way through, I've got some slides, we'll go through the material, but please feel free to make this discussion, to ask questions along the way, and I really am very interested in your thoughts and your experiences. And I guess also to add to your introduction, I'm also a family member of several individuals in my family who have psychosis. And so, to expect to tear up. So it's an important topic, and it's funny, I was thinking about this on the way over. When I'm in my psychiatrist role, I can be very calm and measured, and sometimes as a family member, it's a very different role. So we'll talk a little bit about early intervention in psychosis and some of the new research that's actually really exciting about maybe different ways that we can help identify this condition earlier and actually treat it in a more holistic way, and also the roles that families play. So the take-home message is really that finding young people with psychosis early and treating them is prevention. And there's a framework that we'll talk about called coordinated specialty care, which does seem to be associated with much better outcomes if we can use this model of care. It works, and it also saves money. And how many people, because this is actually, know that the coordinated specialty care, early intervention in psychosis, is a topic that nationally NAMI has taken interest in. I'm wondering how many of you have heard of, I know Kermit you have, but have other people heard about this idea of early intervention in psychosis?
I'm sorry, was there someone before me? I'm not sure. They say that in all the research I've done that as far as getting diagnosed with schizophrenia, it usually happens around age 17 or 18. Is that pretty much all true, that age?
I think sometimes the symptoms occur. Oftentimes there's a huge lag, and that's what we'll talk about. And actually, when people first develop the symptoms, and then there's a lag before when they actually get diagnosed. So that's one of the issues that we wanted to talk about. And then you were...
Well, I've read and heard through NAMI that there's a lot of research that supports the early intervention. Obviously, I'd be interested in addressing how we access that, since access to care and diagnosis is the biggest problem.
Yes, yeah. And I think, and this is why it's nice to make a discussion too, because there's sort of the ideal, and then I think there's also what's happening in New Mexico. So first of all, what the research is showing is that it is important it makes a difference getting help earlier rather than later. And there's this phrase called the duration of untreated psychosis. We'll talk about what psychosis is, but DUP. Currently in the United States, it's about 1 to 2 years. So somebody may be experiencing symptoms of psychosis, but it often takes 1 to 2 years before they actually connect with a mental health clinician, get assessed, and get a diagnosis. And that 1 to 2 years can be very distressing, because people are experiencing these scary symptoms, don't know what to call it, family members don't know what to call it, they don't know where to actually ask for help. Is it a mental health problem? Is it a school problem? Is it a spiritual problem? And so oftentimes there's not a clear route to what is it and where do I need help. And so that 1 to 2 year period can be a really distressing period, and it's also a vulnerable period. So part of this framework for thinking about how to do better early intervention is how do we reduce that 1 to 2 year period so that people have a name for these symptoms and then know where to get help. Ideally, I think nationally and internationally, the idea is actually instead of having this 1 to 2 year period, that really we shorten it to 3 to 4 months. So that people are starting to experience symptoms of psychosis, people know how to recognize them, how to put a name to them, and how to get help to a clinic so that people don't go too long without a diagnosis. Because what we do know and what the research is telling us is that getting help early helps people get back to functioning well. And that the earlier people get help, the more that they have better outcomes in school, work, socially, connecting with families. So in 2015, there was a joint announcement by several federal agencies, NIMH, SAMHSA, and for Medicare and Medicaid, that they wanted to make this a priority. And so there has been some work nationally to try to look at providing more education around first episode psychosis, early intervention, and giving support to states to try to build a system of care. So why focus on psychosis? We know that symptoms of psychosis are treatable, and that that shorter the duration of untreated psychosis, the better the outcomes. The average, I say, is about 1 to 2 years, but many people actually do describe sometimes actually having a period of 6 years where they're having distressing symptoms, don't have a name for it, or there isn't access available to care, and so they're living with those symptoms without treatment. And so again, it takes an active effort really by all of us, as community members, as families, and also as health professionals, so that we all are aware of the early warning signs of psychosis, helping and engaging people in care, and then knowing what resources are available. About 3 out of 100 people will experience a psychotic episode in their lifetime. As you're saying, the onset is often in late adolescence, sometimes in early adulthood. So sometimes it's that sort of 17 to 20, 22, 23. And it also can have multiple causes, and it can occur in multiple different conditions. So I think, as we've mentioned, some of the different mental health conditions. Psychosis can appear in bipolar disorder, major depressive disorder with psychotic features, schizoaffective disorder, schizophrenia, sometimes severe anxiety disorders, substance use disorders, and then actually a range of medical conditions. So medications, neurological diseases, tumors, aging, dementia, liver and kidney failure, and other metabolic conditions. So this really speaks to when somebody's experiencing the symptoms, it is important to have an assessment so that you're working with a healthcare provider to kind of figure out which category and which condition the psychosis is associated with. It is a predominant symptom in schizophrenia. So worldwide, there's about a 1% prevalence of schizophrenia. But schizophrenia is a serious condition, and about a third of all the mental health care spending in the U.S. is actually on schizophrenia treatment. Schizophrenia can have a very good outcome, but also it can have a devastating outcome. Again, if people have symptoms and aren't accessing treatment, about 10% of people with schizophrenia do die by suicide. And then again, if there's indirect causes of schizophrenia, that sometimes people have a hard time working, oftentimes caregivers have a high investment, and unfortunately there's sometimes is an interaction between law enforcement and people with psychotic disorders and schizophrenia. And many times law enforcement doesn't really understand the condition too, and so sometimes that's an abrupt way to interact with the healthcare system. So the World Health Organization rated schizophrenia as the second most burdensome disease in the world after cardiovascular disease. So it's a really important disease, but it's 1%, so 1 out of 100. So it's relatively common, but it's also relatively rare. So not all healthcare providers are familiar with working with people with schizophrenia. So sometimes people don't recognize it. So I mentioned this model of coordinating special care, and we'll talk about the components of that, is associated with improved outcomes for people with psychotic illness and schizophrenia. And so there was a large research study done in the kind of 2008 to 2012 called the RAISE study. And so this was 34 community clinics. These were mental health care clinics So they were randomized either kind of usual treatment, where people with mental health conditions go and get an appointment, get an assessment. So that was and you get mental health treatment as usual, versus this really kind of structured approach to identifying early episode psychosis and providing something called coordinated specialty care, and I'll talk about those components. And so the community mental health clinics that had a coordinated specialty care and a dedicated first episode psychosis program had much, much better outcomes. So people in those programs had a better quality of life. They described having more of a sense of purpose, feeling more motivated, having a lot more just healthier social and emotional interactions with their friends and their families, better functioning, and then feeling like they were more engaged in activities around them. They had more involvement in work and going to school and being involved in work. They were more engaged with their healthcare providers and more engaged in treatment, and they had fewer symptoms of psychosis. Did somebody have a question? I didn't know if you... Okay. So one of the big things about actually the study was a big part of this focus was actually providing a lot of education to community members and to families and to teachers and to healthcare providers who were don't specialize in mental health about the early warning signs of psychosis. Because I said many times people experience them but don't have a name to put to them, and then don't know where to ask for help. So first of all, psychotic experiences are part of the normal human experience. So about 1 in 10 people have heard voices in their lifetime, and that doesn't necessarily mean that there's a mental health condition. It can be normal. It often can happen when you're tired, or at times that people are involved in kind of spiritual endeavors and things, and so it can be very normal to hear voices. So it's about as common as being left-handed to have some experience of hearing things. But psychosis itself refers to changes in the brain that interferes with a person's experience of his or her world. So the symptoms, and we'll talk a little bit more of those, often mean that there's some sort of loss of contact with reality. So people are experiencing hallucinations or delusions, a disorganization in thinking and speech, behavioral and emotional changes, and then sometimes difficulty thinking, and so neurocognitive impairment. Mm-hmm.
When you say hallucinations, do you mean auditory hallucinations, which is not really a hallucination, it's auditory hallucinations, hearing you're born with? Do you mean auditory hallucinations?
And so we'll talk about this. It's a range.
Okay.
So yeah, and I'll talk about the delusions, and I'll kind of go through each of these symptoms. So changes in thinking are delusions, and so these are kind of oftentimes intense fears, where where you can be suspicious of other people, or really kind of convinced something that's happening, and really be quite distressed about this belief that is very intense. And I think we all again have a range of beliefs, but it's sometimes the distress associated with these beliefs that mean that it's a delusion. There's changes in perceptions, which are the hallucinations, and these can be auditory, they can be visual, they can be what's called somatic, so you feel things that aren't there. Olfactory, so you actually can smell things that aren't there. But oftentimes, very common, it can often be hearing things or seeing. Yeah.
In terms of olfactory,
Yeah.
You talk about olfactory hallucinations. Can there be a continuum where you have olfactory heightened senses?
Yeah.
They're not really they're based on an egg might smell like an egg, but it's a heightened.
Yeah. Mm-hmm. Yeah. And that's again when we talk about sometimes the early symptoms too. It is this intensity of sensations. And then the changes in mental processing can be just difficulty organizing your thoughts. So jumbled thoughts, sometimes difficulty communicating. And again, really, we're all on a continuum. So this is that idea that really healthy thinking is very flexible thinking. And so, when we're all at our best, something may happen where somebody doesn't look at us, or somebody we know seems to walk by us and not say hello, and don't make eye contact. And so when we're feeling kind of confident and well, we think, gosh, maybe they just didn't see me. Maybe the sun was in their eyes, or maybe they're really busy. Maybe they were ignoring me, but maybe they just didn't see me. And that's that flexibility of thinking. We sort of think, okay, there's a couple different explanations. The worst possible scenario is they're really mad at me, but maybe there's other possibilities. Cognitive distortions actually happens in a range of conditions, or just a range of emotional states too. If we're stressed, we're really feeling bad, and we did have a fight with somebody recently. A cognitive distortion might be like, oh, that person hates me. They walked right past me, they didn't see me, and they're really mad at me, and nobody likes me, and I don't have any friends, and you can kind of start to get down this sort of tunnel of, I just really feel bad about myself. And so oftentimes we sort of live between the middle and the right, where sometimes we have bad days where we just sort of overinterpret things. And then sometimes we can kind of balance ourselves out and think maybe there's another explanation. The delusions is really crossing over into really kind of very fixed beliefs. So not only did that person just walk by me and they didn't like me, but gosh, maybe they read my mind and they knew that I was thinking, something they didn't want me to think. And you start to really overinterpret why that person didn't make eye contact with you, and you start to get very fixed on all the positive, negative reasons why that person didn't make eye contact with you, and not be able to hear that other explanation of maybe the sun was in their eyes and they just didn't see me. And so again, the delusions I think actually get very distressing, but it's on a continuum. Go ahead.
I have kind of a question I wanted to clarify about the word delusion.
Yeah.
My friend was telling me the other day on the phone for me not to be shy.
Mm-hmm.
And I said, shy? I'm a Taurus, I'm private. But that's something else. But this word delusion, the last time I was involuntarily admitted to the hospital here in Santa Fe, New Mexico, in the ER, they put in my medical records something I don't think they should have put. It's not fair. Because I didn't say anything about religion, but they put something in my medical records saying moderate religious thought insertion delusion.
Right.
What does moderate religious thought insertion delusion mean? I didn't say anything about religion. I said I'm American and I vote. Right. That's all I said.
Yeah. And so it's hard to say what was going on at the moment, but it sounds like that whoever was working with you was worried that maybe your thoughts were getting kind of more in the fixated side of a particular content, but it's hard to say.
Moderate religious thought insertion delusion.
And moderate means that it was sort of in the middle too.
But the delusion word is what I don't get, because I didn't say anything about religion.
Yeah, no, and it's hard to say. But there's also a continuum of perceptions too. So again, people who have 20/20 vision or perfect pitch have really very acute perceptions without error. But also in the middle too, I wear glasses, my vision's not acute. There's also, again, when we get sleep deprived and stressed, many of us have been in this middle area too, where we can hear shadows, maybe we hear a ringing in our ear, we hear sounds, there's that sensitivity to sounds, almost what you're describing, kind of that sensitivity to egg smell. Some of us have had that experience where a normal sensation actually feels very vivid and just a little and distressing. And so sometimes a lot of us will live in this sort of really acute perception and then distorted perception. If it starts to get actually very distorted and very consistently distorted, it can become a hallucination. So people can hear sounds and then they start to hear and interpret voices. Again, the visions, I was talking to one woman who was looking out the window and she was seeing all the trees and then starting to see the shapes in the trees, which we all can see in patterns, but then started to get really scared about the patterns that she was seeing in the trees and what they meant. And that was starting to become less of a distorted perception and more of a hallucination. And so again, a lot of it's around the intensity of, do you have some flexible thinking, oh, that's maybe a misperception, or whether you really believe something is there, and then how distressed you are by it. There's also a continuum, again, and as humans, we have a continuum of thought organization too. So again, executive functioning, that's our ability to plan and to think and to make decisions and to, kind of take some time to make thoughtful decisions and kind of accumulate a lot of complicated information. So sometimes when we're at our best, we can do that. A lot of times we're in this middle where we get distracted, we're not paying attention to things, we have this brain fog. And then if it drifts off too much, people can have serious difficulty kind of concentrating, thinking, making decisions, planning, assimilating information. And so that's, again, when it becomes a mental health symptom, is when people have confusion and jumbled thoughts. So these are in some words of people who've had psychotic illness too. And so somebody was describing the disorganization, because this is often hard. This is a hard time that clinicians often have a hard time picking this up too. It's a little bit easier when somebody says, yes, I hear voices. Then they can kind of check off and say, yes, that's a mental health symptom. The disorganization is a bit more subtle, but it can be very distressing. So in words of one individual, he said, words just jump around in my head. It's hard to tell you what I want to say. And that could be an early symptom of psychosis, but sometimes it doesn't get recognized as that, it just because it's so hard to articulate. Disorganization of behavior and emotions too. And so again, it's if the cues are getting all jumbled. So for example, sometimes people with psychosis can just misread temperature sensations and just other cues. And so for example, wearing a really hot jacket on a hot summer day tells me that something's going on with that person's kind of regulatory system, their temperature system, and then their thinking and able to be kind of plan and respond. And that also, again, sometimes doesn't always get recognized as a sign of psychosis, but it can be. Or again, go ahead.
Can I ask you a question about the language?
Yeah.
I'm actually a specialist in that area.
Yeah.
And can comprehension reflect subtle linguistic difficulties, like almost like you didn't hear like the word but, or connecting things that make it if and then? And they're very subtle linguistic things, not really broad ones, but even subtle.
Yes, and so it actually can, and we'll talk a little bit too. There's not one symptom that's diagnostic, but it's putting together the whole pattern. So absolutely, those kinds of missing out conjunctions and sometimes jumping from word to word,
And even in terms of their comprehension, like
yes, can be part of that disorganization. If it was on its own and it was just a comprehension, it wouldn't be a psychotic disorder, but if it's in the cluster of some of these other symptoms, yes. And again, that kind of disorganization, so sometimes, again, people can be talking about a stat and almost like just the emotional cues get disrupted in their body, and so they start to giggle in a way that just seems odd, but it's almost because the emotions have, the neurons processing our emotions actually get a little jumbled, and so the signals get jumbled. And so people, and again, it can be odd to interact with somebody who's telling you something really sad and really scary, and then they're smiling in this odd way. And it's really actually neurologically that their brain is processing a little bit differently. So it's not just a coping mechanism, their brain is sort of triggering the wrong system.
When you say the brain is processing differently,
Right.
or triggering the wrong system, that seems to suggest that we've somehow demarcated a line between normal human experience and something medical. And a lot of what you've described, I think I could characterize as, say, a deficiency in a person's confidence in discriminating spurious perceptions or stimuli. And that includes even people who, as you said, are very certain of a belief. And it's been my experience that usually people who seem very certain of a belief, when you really stay with that for a while, what emerges is that they actually aren't certain.
Right. Yeah.
And sometimes they're asserting it very strongly because of their need to feel that they can discriminate spurious from a reliable perception. And so I guess I'm just observing that I haven't seen a clear demarcation between normal human experience and a mental problem.
Right. No, and point taken. I'm trying to be careful with my language too, because I think, again, it's really the pattern too. So there's not one symptom that sort of says this is a medical problem, but it's actually the pattern of all the different symptoms and then the distress associated that then starts to put together, gosh, maybe there's some medical treatment that can be helpful. But
even so, that all of that evidence could be described as circumstantial.
Right. Yes. Yeah. And really, my intent too is because I think that you're bringing up a good point, and I think there's a whole other kind of conversation around the medicalization of mental health, and which I think is an important conversation. I think here I'm just sort of thinking, I'm actually really speaking as a clinician in terms of when we think, gosh, there's a condition that we can offer some medical treatment for that may be helpful. And so that is, and again, when we put the pattern together, and if there's a lot of associated distress, that's where I'm sort of, I think all of these things are on a spectrum of normality and part of the human condition. And then there are some symptoms that are just so distressing to the individual and the family around them that then we say, yes, this leads to a diagnosis and this is what we can treat. Is that?
Well, it's the beginning of the discussion.
Right.
What is the best response to a person in crisis?
Right.
Mm-hmm. I mean, I was actually playing around earlier. You mentioned the duration of untreated psychosis. And of course, I think if you're talking about 1 or 2 years that a person is in distress, that nobody's listening.
Right.
That's, and after which you could imagine a person who's in that level of distress might start to be psychotic. But if you can get back to the beginning of that, I was actually playing with the phrase DUP as being a deficiency in understanding people.
It could be.
So I think there's a bit of a danger when you use a phrase like early intervention, that immediately calls to mind specific certain interventions in whatever context we're working, and leaving out other early interventions, such as, for instance, family work.
Right. No, and I think that's a very important perspective. I am coming from the medical model, and so the research around this topic is very much rooted in the medical model, and so I do want to be mindful of language and realize there's sort of different perspectives on this, but probably a lot of my presentation is from the medical model.
Of course, granted, and here I am. The challenge for people like me who do approach it, people, situations that could be held
absolutely
as something thought to be under your purview and not mine.
Right. Yes.
Then it's a challenge for me to say, actually, I think, and I experience this often, that a person, I experienced it 2 days ago, a person comes in with what appeared to be, I was actually sitting there thinking, this is going to end up in the hospital. And I have no idea how we're going to hold this potential liability. But because the whole family was there in the course of talking about it, after about an hour of really outrageous behavior, a secret came out.
Right.
I mean, something that had happened. And once it came out, everything changed. And suddenly this was like just different. And so this is why, not to be contentious, although hard to not be. It ends up there because it's like here, and in my experience, that has happened often. People who have been assessed, diagnosed as you are lifelong, and this is the treatment, and so this is who you're going to be.
Right.
Whereas when we actually get down to finding out what was going on that was driving it, that person was no longer there. With very little reflection looking back to say, how do we account for the fact that we once told that person something about themselves that we suggested we knew for certain was going to be lifelong, that turned out to be completely wrong.
Yeah. No, and I agree. And I think you and I agree more than we disagree too, because I also would say that there's a whole body of literature talking about kind of the outcomes in people who've been diagnosed with schizophrenia, and that they're much more optimistic than I think we had ever realized. And I think oftentimes in the psychiatric system, we think about it as a lifelong condition, but I think there's some, very good literature actually showing that the recovery and how we define recovery is variable, but is much more optimistic than we ever realized too. Okay, and so if you're okay, I'll continue with where I was heading. Okay. So again, another symptom is the changes in mental processing and disorganization too. And I think this is also one that often gets under-recognized by healthcare clinicians too, but it often can be some of the ones that cause some of the most distress. So difficulty with attention, processing speed, difficulty with memory, and then that difficulty sometimes reading people. So somebody might say, I just didn't trust my sense of reading other people, it was all messed up. Or people saying, I just didn't know how to answer that question because I really didn't know the answer. And I worked with a number of different individuals. And again, these are not diagnostic of any of these conditions, But oftentimes when I work with people with psychotic disorders, they'll describe this, that just, I don't want to go to that clinic because they talk too fast and they don't slow down and I can't understand them and they can't understand me. Or again, just really having a hard time, when they go to a healthcare provider who bombards them with questions and kind of goes through a bunch of structured questions, and then the person's saying, I stopped answering because I couldn't understand. And so again, it's hard because it's not a symptom that we sort of write down and check off, but sometimes this is actually a very important early warning sign of some of these conditions. Again, I think there's a lot of emphasis on the hallucinations and what we talk about as the positive symptoms of psychosis. What we do know is that many psychotic illnesses also have negative symptoms, and these can actually be some of the most impairing symptoms. They're also the ones that are most hard to articulate and the most hard to describe and the most hard to kind of really I think that actually medication doesn't work for too, which is also important to know, and that we need to think about a variety of strategies to help people. But see, these are, difficulty with motivation, lack of energy, reduced pleasure in life, having difficulty expressing themselves, and really withdrawing and not socializing as much. And it's actually these, again, when you talk to people with psychotic illnesses and their families, these are actually sometimes the most impairing ones. And sometimes, and I do use antipsychotic medication, and I use medication, but sometimes actually high doses of medication make these symptoms worse, too. And so we often use the medication for the positive symptoms without realizing we're exacerbating these symptoms, which may impair quality of life.
I just wondered, I don't mean to interrupt you, but does that really have an H in it, that word?
Maybe not. I don't know. Which word?
Up there is psychosis.
It does, yes.
It has an H in it?
Mm-hmm.
Yeah.
It doesn't have an extra word in there, letter in there? It doesn't look like the right spelling to me,
Sometimes
psychosis.
we look at words.
Yep.
They're not spelled right.
Yep.
I see the study of,
Mm-hmm.
but I don't see psychosis. They're okay.
Yeah. But yeah, thank you for catching me. I can easily
All
make
right.
typos. So these are, again, some words of people with negative symptoms describing what happened. I stopped caring about how I looked. I even stopped taking a shower. I just feel like being with people is exhausting. And things that used to be fun, like going to the movies, don't seem fun anymore. And it's different from depression. So depression is actually kind of people feel sad and then can have some of these same feelings. But negative symptoms are a little bit different. And just that it's too hard to kind of do these things. And so it's not from a sense of sadness, but actually, again, that executive function and the planning involved is just really, really hard. And so it's more effort to do things that used to be fun that took some activation than with the negative symptoms. So again, these are all, like I say, none of these symptoms are diagnostic. None of these mean that somebody has an illness, a psychotic illness. But it's really looking at the whole pattern. So how long these symptoms have persisted, the intensity, and then also the clustering. So again, having more than one symptom of a number of these symptoms. As a clinician, makes me think, oh, maybe this person is experiencing a psychotic illness. And then really important is, what is the degree of disruption? To what extent does it get in the way of usual activities and responsibilities? And I think this goes to you. All of these symptoms are part of the normal human condition. But if you have a number of these symptoms from a number of these different categories, and it's really impairing your ability to live in the world, and there's not some undercovering, then there's not sort of some, kind of secret in the family or something that kind of explains it and ties it together, but it's really quite enduring. It does make me think that there's a medical condition going on that treatment would be helpful for. Again, what leads to diagnosis? Having hallucinations does not mean a diagnosis of a psychotic disorder, but important to consider the frequency, the distress, the meaning of these experiences to the individual, and the extent to which the experiences interfere with functioning, too, again. So again, culturally, there's a lot of times where it's actually very normal to have hallucinations or perceptual changes. And if the meaning is actually comforting and the meaning is something that makes sense within your community, that again is not a health symptom. It's so again, the meaning of those experiences is important. But again, if the meaning is scary and distressing and really preventing you from living your life, again, that makes me think it's a health symptom. So circumstances, again, that what we know is associated with a psychosis. So trauma. So a lot of times adverse experiences and severe trauma can trigger psychosis. Sensory deprivation. So we know that actually there's been some experience in the military where healthy young men were, put in caves without light or, sleep deprived for 3 or 4 days. And then again, in many healthy people, that can actually trigger many of these symptoms and many of these symptoms of psychosis. It's very normal when people are grieving to see images of their loved one, and again, sometimes those are comforting. But that can happen. Substance use and intoxication with substance use can trigger many of these symptoms. And again, different cultures can experience them to different degrees. And again, they're not necessarily a symptom or diagnostic. But again, depending on the duration, the intensity, the frequency, and the distress. So talking about the science of psychosis a little bit, what we know, what we understand, and I think there's a whole lot more to learn, is that there's some neurotransmitter changes in our brain. Our best understanding is that there's increased activity of the dopamine pathways, so increased dopamine, and also increased sensitivity of the dopamine receptors. And then there's also, and that seems to be associated with some of the perceptual disturbances and the hallucinations. Oftentimes people with long-term psychotic disorders do have a reduction in the gray matter, which is the nerve cells and the neurons. And so there's just less, over time there's a little bit less density in the brain. And then the white matter is the, again, the kind of the coverings of the nerve cells. And there's disorganization. So we have different fibers that connect the brain regions that have a different organization pattern than in people without psychotic illness. And so these can be seen with MRI images and with different brain imaging. And so it's interesting that some of these changes, when they've looked at MRIs of people who had family members with a psychotic illness and were young and had, but didn't actually have symptoms, they actually did have some of these changes on their MRIs years before they actually developed the illness. And so it does seem to be something over time. So you do see these changes in people who've had illness for many years, but you actually can pick them up young. At this point, it's sort of really an emerging area of research. It's not like you can do an MRI, see these signs, and go on to predict who might have these illnesses, but it is an area of something that we would like to learn more about. We also know that there's this idea of the stress vulnerability model of psychosis, that there's a number of many different genes that are associated with psychosis. And so there is a family history. So oftentimes, as again, I have a number of people in my family with psychotic illness. And so again, there is a sense that it's sort of passed from one generation to another, and we do know that. And that's having a family history of psychosis or schizophrenia is a risk factor. There were some large studies in the Netherlands or in Scandinavia, looking at large databases too, of people who had twins. So both twins would have the family history and the genetic predisposition for schizophrenia. And then if one child went on to either have adversity or trauma, they were much more likely to develop a psychotic illness than the child that didn't have that adversity. There's been also some similar studies looking, I think in Australia, New Zealand, and Israel, looking at twins and again exposure to cannabis too. So again, people may have that genetic susceptibility, and then there may be some sort of trigger later on in their life too, the trauma, social stressors, substance use that actually seems to be able to trigger those genes to actually triggering the illness. And then what we know, too, is that if somebody actually does end up getting diagnosed with the illness, too, this goes back to the prognosis and the outcomes, too, that there's a huge variety in what happens, too. And so it often, the ability of somebody's social support system, the family that they have, the resources that they have actually really can change the trajectory of their illness. And people with a lot of support, and especially family support, sometimes have a very different experience than people who don't have that contact with their families. So a lot of times when we work with individuals, it's that idea of that bucket and kind of, that so much stress and too much stress may actually kind of really just overfill your bucket too. So thinking about what are ways to really reduce if you have if you have a susceptibility to psychotic illness, how do you really support yourself and keep yourself well and reduce the chances of that stress really kind of triggering either an episode or a full-blown illness? So thinking about self-care, connection to social support, family support, regular exercise. Sometimes medication can be part of that. Healthy eating, spirituality, sleep, and actually regular sleep is a huge part. Avoiding substance use, recognizing coping skills, and then community resources include partly sometimes healthcare, but also we'll talk about some of the other community resources that are helpful. NAMI is actually a huge resource that many families and individuals find helpful. What we also know too neurologically that is psychosis creates a lot of unusual sensitivity, and this is what you're talking about too, to sensory stimulation. So sometimes to heat, to clothing, to noises, to temperature, to wind, but also to prolonged stress, to strenuous demands. So, for example, somebody I'm working with right now, he's getting his PhD in math, and he is incredibly smart. But he does have a psychotic illness too, and so sometimes when he's taking too many classes, or if the classes change, it's that can trigger things for him too. And so working out how to help him with his class schedule and how to help support him so that he can stay well or have fewer stresses so that he can kind of get through the stressful period without having a relapse. Again, rapid change too, and so really kind of thinking about how to anticipate changes. But complexity can also be triggering. Again, social disruption, and we all have messy families with lives and arguments and things, and that can be triggering. We do know that drugs and alcohol do, people with psychosis or sensitivity psychosis do seem to be especially sensitive to drugs and alcohol, and that can exacerbate things. And then really any negative emotional experience. So again, I work with a lot of people who are doing really well, and then, life happens. And so maybe there'll be a death in the family, or there'll be, or things will happen. They'll fail a class, or, their boss will change at work and they won't have a boss who's not so understanding. And those kind of negative emotional experiences can really, it can be very difficult for somebody with psychotic disorder to kind of adjust to those experiences too. So again, what causes psychosis? There may be genetic factors that may or may not be known to the family, and then all the different stresses, biological stresses, malnutrition. There's some evidence that early birth trauma and obstetrical complications may actually be one of the factors that kind of maybe triggers a higher risk of schizophrenia, and then the stress, and then again that idea that some experiences may be particularly stressful to vulnerable individuals, but not necessarily to everyone too. And so because that sensitivity to stresses that other people may be able to cope with just fine, may be very triggering. Again, the factors that worsen psychotic disorders, the substance use. The longer somebody goes without any engagement in healthcare, so that duration of untreated psychosis, stressful experiences, so trauma, tense interpersonal interactions and feeling criticized, we'll talk about that. Again, expectations to function at a higher level than one can at the time, and that can be really difficult too. So if somebody, oftentimes, especially when we're talking about early psychosis, somebody may have been a really good student, doing really well at school, used to succeeding really well, start to have these symptoms, and they and their families will often want them to go back to that same level. And they may be able to get back to that same level, but they may need to go at a different pace. And again, I'm thinking about this PhD math student that I have no doubt he is going to get through this PhD, but it's going to take him a little while longer, and he won't go as rapidly as he might have if he hadn't developed this illness. And oftentimes, again, that's sort of set too. So if you've sort of set your expectation that I'm going to get through my undergrad in 4 years, and then you have this illness that means that you end up taking time out or going slower or taking fewer courses. If you feel like you're failing because you're not finishing in 4 years, or you're not whatever, and whatever that is too, if it's a job or whatever your goal is, and you've sort of set yourself a goal that maybe needs to be modified because you've developed this illness, that feeling of failing can actually add to that stress. And so as people supporting people and individuals too, really kind of helping them know that it's okay. It's a huge accomplishment. If you set yourself a goal and you get there, Sometimes it'll take a little longer. Sometimes it's not the path that you thought, but feeling really proud of your accomplishments is really, really important. So we know what works is support by key relationships and families. There has been, since the 1970s, there's been a huge amount of literature about the role that families play in supporting people with psychotic disorders too, and that if people have good relationships with their families, they're less likely to need hospitalizations, less likely to need really high doses of medication, and more likely to just to be have a meaningful life and feeling good about their life too. And so sometimes it's hard to really figure out how to support those family relationships because we know that they're so important. Lower stress during recovery. There's some evidence that that therapies work too, helping people retrain their thinking patterns, their feeling patterns, noticing when they're having a cognitive distortion, what are other alternative explanations. We know that staying involved in school and work, at the level that the person experiences success. So not setting the expectations so high that the person sort of feels like I've got to do this and I'm failing all the time, because that sets people, that can make things worse. But finding a place where somebody has meaning, has purpose, feels valued, enjoys what they're doing, can be really, really healthy and really protective. Again, medication can be helpful to decrease the dopamine pathway activity. And then also sometimes if there's mood symptoms along too, medications to treat associated mood swings and depression can be helpful. So as I said, the study for the RAISE study looked at all of these components too. And I think what was unusual about this study is usually the research has been sort of looking at one component, the effect of family therapy or the effect of medication on this illness too. And so this one looked at all the literature and sort of said, okay, this is what we know helps. So engaging people early and helping people understand what are the symptoms so they can ask for help early. Getting an accurate assessment and diagnosis. I think very often, because some of these symptoms are subtle, they'll go to a healthcare provider who will come up with a different diagnosis, and the person isn't actually necessarily getting the referrals and the treatment that they need. The individual psychotherapy, so there's two different therapies that have been that were studied. There's CBT for psychosis, which again is like looking at alternative explanations and really sort of nurturing that flexibility of thinking if somebody has an experience. A distressing experience, and then individual resiliency training too, which is another manualized treatment, looking at all the strengths that the person has and their resilience, and really helping to kind of maximize those. And so that's an important part, including family psychoeducation and support, medication, and then also access to supported education employment. So this is sort of the ideal program for first episode psychosis, or actually any component of psychosis, is having all of these elements. And so that was what they studied and showed. In that RAISE trial, they sort of had normal mental health care versus programs that had all these 6 elements, and they were able to show much better outcomes if you had all 6. Other components of this is this idea of team-based care too. So you have a team of nurses, psychiatrists, therapists, and then also peers with lived experience of mental illness who are part of that team. And so that team is available to the individual and their family. Some case management, again, to help people either access benefits, access care, access physical health care. Employment and education support. So this was also part of the model, and I know this isn't always accessible everywhere, but somebody who's working with the school system to make sure that the individual is entitled to accommodations and knows what accommodations are available, or again, working with employers to help either find jobs, help them with writing CVs, helping them with job coaching, coaching for interviews. The psychotherapy, having access to family education and support, and then again the pharmacotherapy, and again the big emphasis was on using lower doses too, and so not using real high doses of medication, but lower doses and then increasing as needed to help that individual. And then coordination with primary care too, so that people are staying physically well. The other element that I mentioned earlier is that this programs in the RAISE study also had community outreach to, again, try to reduce stigma around the mental health conditions, to provide information to people about psychotic illness, and then to help people understand the early stages of mental illness and what's called the prodrome. So the prodrome is often the subtle symptoms that people might be experiencing before they become really acutely or obviously unwell, but maybe these early signs of not being able to track, kind of withdrawing or isolating, sometimes the negative symptoms, and these are often the symptoms too that people really sometimes have a hard time identifying.
Did you say?
Prodrome?
Yeah, but
That's a word I've never seen.
Which one?
Prodromal.
Prodrome. So that's the period where people start to experience subtle symptoms before kind of a full before it becomes clear that it's a full medical condition. And so examples might be somebody who was really normally like a teenager who normally kind of went to school, was engaged in sports, and then just started withdrawing and stopped. And so then a year later, they end up getting a diagnosis of schizophrenia, and then they and the family will look back and say, oh gosh, actually 9th grade, something was wrong and we just didn't know what it was. So that's the prodrome. Prodrome itself doesn't always lead to a diagnosis, but the idea is actually if we can get people connected to care during that prodrome period, maybe with some supports, they don't end up having a dramatic flare. And again, these clinics see and provide treatment individually, and we do have a clinic at UNM, so I'll talk a little bit more of that, but they also provide consultation and to other clinics in the state too. And so again, provide information around kind of what would be the best practices, how to work with people with early psychosis. So they have their own clinics that they're seeing, and then they also do a lot of outreach to other clinics. So again, that idea of community mapping, that it's not just a sort of a clinic and a healthcare system that is the best ideal treatment for first episode psychosis, but that's that whole idea of actually kind of being connected to churches and community groups and public health agencies and primary care and schools and, both college, so that it's the whole kind of community sort of knowing, okay, this is actually what early warning signs of psychosis are, and then you can get to the clinic. Because I think by the time people come to the clinic or on that waiting list and actually get to that appointment, people have often been living with some of these distressing symptoms for longer. So the idea is the early intervention program would need to be connected to all these different community resources, and NAMI, again, is an important one. Again, there's been a lot of work at looking at how to do a better job at diagnosis and screening and assessment. So the Prodrum, going back to that word, Prodrum questionnaire is a new questionnaire that people are using. Because again, I think oftentimes when you come into a clinic, traditionally people just sort of say, okay, are you hearing voices? Are you seeing things? And that would lead to the diagnosis. This is actually trying to give healthcare providers a little bit more subtle language to kind of pick up these symptoms before they become so overt. So it's 21 questions that clinicians can use. And so some of the examples of the questions that are on the screening instruments are things like, do familiar surroundings sometimes seem strange, confusing, threatening, or unreal to you? Have you heard unusual sounds like banging, clicking, hissing, clapping, or ringing in your ears? Do you feel that parts of your body have changed in some way, or that parts of your body are working differently? Are your thoughts so strong that sometimes you can almost hear them? And have you seen unusual things like flashes, flames, blinding light, or geometric figures? And again, it's a different instrument than oftentimes that we use in healthcare, because somebody could answer yes to all of these, and it still may not be an illness. It may not be a psychotic disorder. But it starts to ask questions to pick up some of these subtle symptoms that then the clinician can kind of put together in terms of like, okay, and this person is distressed, and this is going on, and putting together that pattern. So none of these are questions that actually mean that somebody has a diagnosis, but they start to help people put together a pattern to catching things early. Does that make sense? And it's interesting as I work with healthcare providers too. It's a different way of it's not a sort of yes or no, yes, they have a high glucose, yes, they have diabetes. It's sort of finding the words to kind of try to catch these symptoms earlier on.
Since you asked if it makes sense.
Yes.
For me, the concept of prodromal, and I've only thought of this in this moment, so I'll indulge it. it's a moral hazard.
Mm-hmm.
It's a gate through which you can understand failure to meet a person's human needs as it's an opportunity to reframe it as a medical problem. And I think a lot of times when people are told you have prodromal schizophrenia, I mean, it's like saying you don't yet have something that may not really be.
Right.
And that's very dangerous.
Right. And and I agree there. It's actually because there's no way to say, there's never a way to say this person had prodromal schizophrenia until they developed schizophrenia, and then you say, aha, there was the prodrome. So it's not, again, as I think you met when I work with terminal patients too, sometimes I'm thinking, oh my goodness, I think this person is dying, but I can never be definitive and say, yes, this person's gonna, we're all gonna die, but I can't say this person's gonna die until they pass away, and I think, yes, they were dying. So I think it's a retrospective description, but there's also something there that we can recognize a pattern
But I think
concern.
it's very dangerous
Right.
road. And the perspective I come from, I think you have heard of the open dialogue perspective, which comes out of an area of Finland where they basically, partly because they had the highest rate of schizophrenia in Europe, and their hospitals were overrun, they realized they had to rethink everything.
Right.
And in this particular area, what they did was they began their form of early treatment and early intervention was to respond within 24 to 48 hours to the crisis with family and network therapy. And the ultimate outcome of that, if you accept the research, which I do, is that they reduce their incidence of schizophrenia to practically zero.
Right.
Such that if you now ask a treater there, how do you define schizophrenia?
Right.
They say it's somebody that we failed to help. They don't really they don't review it. They don't even then, when they have failed, say this was a medical problem that we missed.
Right.
They say we didn't figure out how to reach that person. But the important thing, even though they do have a very low incidence of people who meet criteria, meaning that the crisis that their first episode of psychosis was not met and responded to, such that it proceeded. They didn't solve the problem within 6 months. At the 6-month point, they then meet criteria for schizophrenia, which is again something that I would question as being a medical demarcation.
Yeah. No, and again, this I think there really is a large conversation around the just the medicalization of mental health conditions and symptoms. But I do come from the perspective too that some of these conditions are so distressing, and I do think that the combination of treatments can be very helpful.
I think medication can be very helpful, but I think what is an important discussion is why. I think people conclude automatically from the fact that a medication can either be or seem to be helpful, that it was a medical problem.
Right.
And I question that, because I think if somebody is in distress, medication can help them remember that it's possible to not be in distress.
And I do want to repeat that too, and that medication is only a slice, that it really, what we do know is it's all 6 components. So it's the family therapy, it's the support, it's the individual therapy, it's the connecting people to housing and employment and education, as well as the medication. So when I'm thinking about a medical problem too, I'm thinking about a problem that causes a lot of distress and that there are numerous parts of the treatment that are important too.
I just kind of want to clarify something.
Yeah.
When you mentioned Prodrum, immediately I thought of with stroke or something like that, or migraines.
Right,
Coming on.
like an aura, yeah.
Yes, and because they call it this, I think they call it Prodrum with stroke. Migraines also.
Right, yeah.
So I kind of took it that way, like, is that how you might see it?
And so it is, and so this is where I know that, that Kermit, you have a different perspective, but too, it often is, it's really is the subtle symptoms that in retrospect preceded an event. And I think there is this big debate, is like, if we can actually intervene early during this subtle period, can we change the course of the illness? Can we prevent the illness? And I think I think the answer there is that we don't know, but we know that if we can actually intervene early during these subtle symptoms, we can alter the course, and that it's better to intervene earlier. I don't know. I think there is a debate about whether we can prevent the illness or not by intervening at that point. We also know that during that area, those subtle symptoms don't always lead to schizophrenia too. So that, or don't always lead to psychosis. So many of us will have those subtle symptoms in our life when we're under stress, and it may just pass without treatment. So does that?
I have it, yeah.
Yes.
I've been stuck since you mentioned the word frequency.
Right.
And it appeared there.
Okay.
Like, how often is it psychosis or hallucinations, or the psychosis mostly? But as far as being a psychiatry or professional,
Yeah.
how do you feel about the word frequency being all week on the radio? I've been hearing songs like "Today Freak Out," and she's a very freaky girl, and
Right.
freak out, and the word frequency being loud because the frequency of it.
Right.
But I remember this one movie where the whole movie, this man was trying to find the FM frequency. He was on the AM frequency in the whole movie. Is there anybody on the FM frequency? The whole movie, and at the end,
Yeah.
but this word frequency, it's so unethical, because like in my car, I'll get in it and I'll turn on the radio and I will have just said something, and like you say it and they play it, and that can make somebody almost schizophrenic.
Right.
Like, I'll just be talking with someone and I'll say, and I think it's so unethical, because music is something that releases stress
Right.
for me, and being already diagnosed with the mental disorder, like you say it and they play it when you put on your radio, it's so unethical and so unfair. But I've been hearing freak out songs all week with the word freak in
Right.
it. Yeah.
Thank you. I hadn't thought about that other meaning of frequency. I was just meaning if it happens lots and lots, so a lot of times, and it's distressing. So I was thinking frequency in terms of something that happens oftentimes.
And there's nothing you can really do if it's unethical, but I think
Right.
somebody's trying to avoid
Yeah.
a civil rights thing, trying to avoid a civil rights
Yeah.
lawsuit by using something, I don't know how they do it on your radio. You turn it on and it just happens to be, isn't it ironic? Yeah, I really do think.
Yeah, but
It's just too much.
It's a good point. I hadn't thought about that other definition of frequency. So again, what we know about the family psychoeducation, when healthcare providers partner with families early in the early phases, it really does help preserve family connections. And it's interesting. I work on the ACT team, so assertive community treatment. It's actually many of the individuals that I'm working with have had psychotic illness for many years. Most of them are actually disconnected from their family. And when I work, it's actually really nice to work with younger individuals who still have those family connections, and to be able to help really kind of work with the family and the individual to help to preserve those connections too. Because it's oftentimes by the time they get to me in their 50s and 60s, they have lost those connections. So that's the other nice bit about working with people early, when they still really are connected with their families. What we do know, though, is that there is this sort of complicated interaction between family interactions and patient symptoms. So ultimately, we know that it's really, really good for families to be involved, and that the love and the support from families is really protective. But I don't know how are people familiar with that term, or have they come across that idea of expressed emotion? Yeah. And this is a hard one too. And again, as a family member, I can be in my clinician role, I can be all calm and I can say the right things and I can tolerate things. Sometimes as a family member, I say exactly the wrong thing and my anxiety rises up. and I'm not that calm person. And so, because I think psychosis is scary for all of us, it's scary for the individual who's experiencing it, and then for the family member too. And so sometimes as family members, we can be kind of have some critical tone or sort of a tense tone in our voice. Make comments about like, why can't you do this? Sometimes it's that anxiety that we're really worried about that person, and so that comes across as sort of tense and overly involved. Or sometimes we're just burnt out, and then we're not as warm. So again, when I'm sort of being in my clinician role, I can be warm, I can be patient, and sometimes I'm like, oh my goodness, and I just went home and I totally said the wrong thing in the wrong tone. But I also know that tone is really important, and so when I'm using that wrong tone, that that my family member actually gets really exacerbated, and it makes them worse, and it makes their psychosis worse, and we just spiral. And so it's sometimes also it's easy to kind of cognitively know it, and then it's so much harder to actually practice it. But so we do know that as much as family members can really kind of work on that warmth in their tone, that patience, it really does help their loved one. Did you have a question?
No, but I want to make a comment. I think that in many different walks of life, or occupations and so on, we could experience similar things. I worked for corrections for a number of years, and in our training about mental illness and drug use and this and that and the other, of course I heard some good things, but my emotions weren't stirred up.
Right.
Because I didn't have an emotional investment in those individuals. But my daughter is 34 and she has bipolar. She also has ADD, and the other day she says she thinks she has PTSD. Really complex individual.
Right.
And dealing with her is like a totally different ballgame. You know, it's so difficult to keep my emotions under check and be logical and be helpful instead of critical and other things like that. And so I think that's one example of the expressed emotion. And like you're saying, family is different than professional, occupation and whatever. And actually very stressful dealing with in that way with family that's in your face and feeling, for my part, feeling so helpless sometimes.
Yeah. And it comes because we care, because we're worried, because we're anxious, because we're frustrated. And those are all genuine emotions. And we're not robots, so we can't keep that out of our voice and our tone. But unfortunately, the more it rises up and it wells within us and it comes out in our tone, that the person with the illness feels it and then actually becomes more symptomatic, and so it does spiral. And so as much as we can kind of figure out how to take a break, how to seek help, seek support, notice it in our own bodies and our own tones, voices when it comes out. A lot of the first step is really noticing it, and then kind of noticing, okay, I'm gonna, kind of every day, kind of making that renewed commitment of sort of, okay, let's check it, and let's knowing again that it's an illness, that the person's not doing it deliberately or not having these symptoms deliberately, and that there is this interaction between families and supports and friends and the individual with the illness.
I'd like to propose.
Yes.
Again, because this is a thought that's just coming out indulgent. I'd like to propose that if a person says they have ADD and PTSD, then what they have is PTSD. And that's been, I know that seems like a presumptuously categorical statement, but that's coming from my experience. When, usually, I'm just going to say that if somebody's saying I have ADD, PTSD, what you eventually find is that they have PTSD, they have anxiety, they have stress, and that manifests in these ways. I think I could go further, but that's what I'll say.
I just want to speak up a little bit there. No offense, hopefully, but my daughter and I both have been diagnosed with ADD, and I cope with it really well. And I don't think that I have PTSD. I had a really good upbringing, family structure, everything, and I feel like I've been very secure in who I am. Now, you might be talking about exceptions, I don't know, but I just wanted to say that from my point of view, it doesn't seem to apply across the board.
I'm proposing it as a point of discussion, but we will continue to have.
We can,
And I don't know anything about Ritalin, but everything I've read about ADD, attention deficit disorder, on studies, is that the parents, mom and dad, if there's two parents, usually in the kid that's age 4, 5, 6 years old, there's a standard test that's pretty standard that the parents usually know by age 5, 6, 7 years old. That standard test is pretty accurate to know if they had it as a kid, they still have it.
Yeah. And I think with all these mental health conditions, it's hard. It's hard because they're all part of the human condition too. So it's again, it kind of goes back to the distress and the impairment and the patterns of symptoms is and again whether or not treatment is helpful. So again, some other kind of going back to psychosis and some of the skills for families. So really kind of again, hopefully the ideally is as having an alliance with the healthcare provider and the healthcare team and the individual who has the condition. Really, there's so much stigma around mental health there, and especially around psychosis. So to all of us kind of working together to address that stigma. Again, really working on how to kind of keep that social network alive too. So both as a family and then also whatever. And again, it's oftentimes it's interesting because psychosis can sometimes hit during adolescence too, where that's a time people are forming their own new networks. So how to support them in the family and kind of know that they're also having new networks and whether those are healthy or good. Those are all things to balance. Again, skills around helping us all to communicate better. Knowing that, again, with many health conditions and psychotic disorders, there can be crisis. And again, life happens, things can trigger crises. And so how to prevent them, how to anticipate them, where to go when you need those sort of help. Again, treatment adherence. And again, not just the medication, but if somebody's doing well in therapy can actually be hard to adhere to, too. So if the therapist is sort of pushing you to learn new skills, sometimes it's easy to just sort of not want to go. So thinking about as again, how to stay connected to treatment. And then, and again, as a family, how to reduce anxiety and arousal. What happens when we all get anxious, when we all get stressed? How do we recognize when it's happening? And then how do we all learn how to take a break? And what's a way to sort of notice that we're all getting worked up and then calm down so that we're not triggering each other? So again, some key strategies for families who live with psychosis is trying as much as possible to minimize internal family stressors, really strengthening relationships, and making a commitment to trying to create an optimal protective home environment. As really kind of striving towards reducing intensity when we all have intense emotions and fears and stresses, to try to reduce that, to reduce the anxiety. That over-involvement is difficult because you want to protect and you want to care for the person, but how to do that in a way that doesn't feel intrusive and lets that person be an individual and an adult. Again, noticing when you're feeling negative and critical, kind of how to catch it and how to check it. And then really buffering external stressors. So a lot of it is really, again, I think NAMI is key in being able to provide an avenue for getting some support and knowing where to go for support. And then always being recognizing that having really high expectations is good. And so we want people to have expectations of themselves, but if we set them too high and then people are constantly feeling like they're failing, that's demoralizing. And so kind of figuring out what's a realistic, and again for the individual at different points in their life, what's a reasonable expectation, what's a reasonable kind of demands, again, if somebody's living an adult is at home, what are the parameters, what's okay, what's not okay, and what's setting it too high that the person can't meet and they always feel like they're failing, but what's setting it too low so you're not treating them as an adult and an individual who has agency and ability. And so sometimes actually, and again, checking those, if you've, sometimes you have to readjust those expectations. It's nice again to have a peer group to sort of balance those off of each other, sort of thinking, okay, I set this expectation, is that okay? Is that a good boundary? Is that too high, too low? Because sometimes they do need to be readjusted. Again, the other component is the employment and education specialist. So the employment specialists, these are often clinicians who work with supported education and employment. Again, do things like job coaching, resume CV building, connecting people with employers. And then again, kind of being aware with the ADA Act too. And so oftentimes, again, on ACT teams, we also have employment and education specialists. and also say, hey, by the way, this person's entitled to this accommodation. Can you write me a letter saying this, and then I will sign off on it. But it's actually really helpful for somebody else to have done the background about what the entitlements are, and then offering that to the person. Then I can sign off on those. So education, supported education might help sitting with the person and helping them develop what their educational goals are, exploring educational programs, helping them walk through the process of registering for college or classes or online classes, helping them navigate financial aid assistance, and again, finding out how to identify what accommodations and how to request them from their teachers. Sometimes it's actually, especially when we think about middle school and high school, is helping them with organizational skills development too, because that can be impacted, as we talked about the executive function, is coming up with a planner and how to schedule your homework. If you've got an assignment or a big project due at the end of the semester, how do you plan it so that you do a little each week so that you can make sure that you get it done by the end of the semester? And then again, talking about really helping that person think through, do they want to disclose their mental illness or not? So sometimes if you request an accommodation, you do have to disclose. Maybe that's not the right time in your life to do that. And so thinking through, having somebody to think through all those questions about whether or not you do identify yourself as having a mental health condition, whether you don't, who you reveal that to, where it's safe, where it's okay. And then again, for students in middle and high school, working with an IEP team or a 504 preparation, which are some educational supports within the school system.
Just want to give you a heads up.
Yeah.
We have about 5 minutes, so they're going to kick us out of the building.
Okay, all right. So I'm going to skip through that. So the other one was talking more about kind of some of the services with supported employment. So again, in summary, it's sort of really, again, not just one treatment, but we do, all these prongs are real key pieces. And I think I may have, some of the common features, again, really kind of working with people from a shared decision-making process too. So the individual, primarily the individual, and then connecting with their family too. But that providing enough information to the individual so they're making the choices around, how much of all these different services they want to participate in, what makes sense for them. Really coming from recovery orientation that we believe people can recover, people can have purpose and meaning in their life. And then again, as they're thinking through the treatment plan, really being collaborative around that too. So the person themselves guides it, involving families and natural supports. And I did want to give people this resource too. So we only have one of these specialty coordinated care programs in the state. I'm really hoping that we can get them disseminated around the state. But the UNM Early Clinic is the one right now, I think probably because Albuquerque has the highest population density that they were able to do this. The phone number there is, please write this down and please call them too. So they do provide services, but they also do provide consultation on this model to clinics around the state too, if they're interested.
NM Early.
Yes, is the phone number, 1888.
The early bird gets to worm.
Yes.
Do you want to open up for questions?
I do, yes. I realize we're about to get kicked out, so yes.
Facebook. Yeah, a few minutes. So this viewer asks, it's interesting to me to read about testing of psychedelic substances like ketamine and psilocybin to treat depression. Is there a cautionary message about inducing psychosis to treat depression?
Yes, so I think this is a whole other emerging field, and there actually have been very promising results for the treatment of pure depression without psychosis. So what my understanding is in these studies, they have the people who participate in these studies have had only really pure depression. They haven't had early symptoms of psychosis. They've done a lot of work kind of really making sure that somebody doesn't have some of these subtle symptoms, prodromal symptoms, before they treat somebody with ketamine or some of the hallucinogens. Because I think that would be a worry, and I don't think we know what that would be, what that would look like.
I'm aware that for certain medical issues, there's help through the indigent fund. is there some kind of a fund that would help with the assessment and treatment of mental illness?
Yeah, so there are some state funds for this, and so most clinics do receive some state funds too. So there are an array of community mental health centers around the state. And so all of these, I would encourage anybody, even if they don't have insurance or don't have payment, to please contact them, because they do have some state funds that can then provide care even if somebody doesn't have insurance. And also, there's also a string of clinics called Federally Qualified Health Centers, FQHCs, too, that have primary care that usually have some behavioral health support. So again, if somebody doesn't have insurance, there is care. I realize that there's wait lists and it's underfunded and everything else, but there is care in almost every county in the state. You had a question?
Yeah, but do you mind working up this briefly?
Yes, yeah.
And then I do have a question just for this group in general. I'm going to get a brochure. So I assume there's a main contact person, I'm for sure, because I'd love to talk to people about their experiences, but getting help in New Mexico.
Yes.
Okay.
I will connect with my mom. She's the president, and she can tell you what she knows.
Okay, excellent.
Yes, absolutely. And we should get your email and stuff.
I would also, and I don't know if people are familiar, there's a state website called the New Mexico Behavioral Health Network of Care, and they've done a pretty good job of putting every single mental health agency down there. So you can search it by zip code and by there's different search categories too, because I think we don't have enough mental health treatment in the state, but that can give you some guidance, especially in some of the different communities around
What
what's
is that
available.
called?
New Mexico Behavioral Health Network of Care. And it's a clunky website, but it does list pretty much every agency that offers some sort of mental health treatment.
Thank you very much.
Thank you.